Welcome to the Group 1 presentation on pulmonary tuberculosis. This will be a video explanation of our concept map, documenting our arrival at this diagnosis, informed by this image, our assessment findings, patient symptoms, and knowledge of pathophysiology. All information and case study will be attached at the end for your reference. We begin with the head-to-toe assessment. The neurological system is a great place to start, as a lot of the information can be gathered through the initial general survey. If the patient is speaking to you, they're looking at you, and they're moving around the room on their own, then you know that the patient is for the most part neurologically intact. The cardiovascular assessment involves the auscultation of the heart sounds and checking the peripheral areas for things like edema, capillary refill, and peripheral pulses. In this case, the patient is found to be febrile, and their heart rate at rest at 99 is slightly elevated. Next, you may want to look at areas such as the gastrointestinal or genitourinary system. In this case, through inspection, auscultation, and palpation, these areas show no abnormal findings despite the patient's other symptoms. These pieces of objective data are underlined by the subjective data, or the patient complaints. The patient reports fevers and chills, a 3-month history of productive cough, greenish sputum, and unintentional weight loss. These are underlined by a shortness of breath, poor appetite, and depressive symptoms.
A focused respiratory assessment is necessary to conduct, given the concerning respiratory symptoms voiced by the patient in his chief complaint. Key features of the focused respiratory exam involve collection of objective data and include measurement of respiratory rate and oxygen saturation, a visual inspection to detect visual symptoms like increased work of breathing, palpation to assess for symmetrical chest expansion and changes in vocal fremitus, and auscultation of the anterior and posterior chest for adventitious breath sounds. Abnormal assessment findings for our patient are indicated on the slide in red.
Some risk factors that can increase the prevalence of tuberculosis will include people over 60 years old, those living in crowded areas, especially with poor living conditions, people from countries like China with high prevalence of active TB, people that are malnourished, especially as patient has had unintentional weight loss for 3 months, those who smoke and abuse alcohol, and people living with chronic disease conditions like diabetes and cancer.
Labs and diagnostic testing starts off with initial symptom screen, looking at the client's history, and identifies any indicative signs and symptoms that can correlate to a specific disease such as TB. A TB test involves an intradermal injection that tests client response to a certain fluid that indicates TB infection. Nucleic acid amplification testing, or NAT, is a sputum culture that looks into if the patient has M. tuberculosis, as well as get a snapshot of any antibiotic resistances such as rifampin. The interferon gamma release assays, or IGRA, involves a blood test that measures immune activities and white blood cell response when exposed to certain antigens. And lastly, X-ray testing provides a picture of the lungs to detect any abnormalities and the progression of the disease, noting certain immune bodies such as granulomas that are indicative of TB. The pathogenesis starts with aerosolization, where a person with active TB expires through coughing or talking, and a susceptible person breathes the particles. The immune system response and macrophages trigger angiogenesis and increase vascularization as it recruits more immune cells. The bacteria itself prevents being eaten and destroyed as it starts replicating and spreading more in the lungs. M. tuberculosis then migrates from the alveoli to the lung tissue, and the immune system forms granulomas around the infected areas. This helps the bacteria from spreading systemically as the immune cells destroy the bacteria from the inside. These granulomas are seen as gun complexes on an X-ray.
The pathophysiology will be explained in relevance to the patient's primary presenting issues, which begin from the acute inflammatory response to the M. tuberculosis infection. First, body cells are recruited and destroyed in the process of killing the bacteria. This, coupled with the overall immune response in addition to the buildup of bacteria in the alveoli, lead to fluid backup, which leads to sputum production, explaining the productive cough. The active inflammatory response leads to a rise in leptin levels, reducing appetite, while cytokines are released throughout the body. Such substances, such as TNF-A, increase the ubiquitin proteasome pathway activity, causing muscle protein degradation. Others decrease MyoD proteins and inhibit mRNA activation for myosin synthesis. Both leptin and cytokine pathways lead to unintentional weight loss. Impaired gas exchange and systemic manifestations of fever explain the other following presenting issues the patient is displaying.
There are several nursing interventions that are needed to manage tuberculosis. The patient must adequately get enough nutrition. This can be monitored through their input and output, encouraging the patient to eat small, frequent meals that are high in protein and carbohydrates to promote recovery, and monitoring the frequency, the quality, the quantity of their stools. It is also important to monitor for anorexia, nausea, and vomiting, as these are possible side effects of the medications.
With regards to the respiratory system, it is important to promote proper airway clearance for our patient to minimize any adverse effects related to obstruction. This involves assessing the respiratory function, positioning the patient in semi or high Fowlers to maximize lung expansion, encourage deep breathing and coughs, assess the ability to clear secretions from the mouth and ability to effectively cough, and suctioning as necessary, maintaining a fluid intake of at least 3 liters to help thin secretions, and humidify inspired air and oxygen to thin secretions and prevent drying of the mucous membranes.
It is also important to promote proper gas exchange. The nurse must assess for abnormal breathing patterns, breath sounds, chest wall expansion, and changes in cognition, as these can be caused by hypoxia. The nurse can demonstrate and encourage pursed up breathing during exhalation to prevent atelectasis. Supplemental oxygen and bed rest can aid with oxygen consumption and demand. Lastly, the nurse can monitor arterial blood gases, as a decrease in oxygen or increase in CO2 may signify the need to change oxygenation therapy interventions.
The gold standard treatment for active phase tuberculosis involves the following 4 medications: isoniazid, rifampin, pyrazinamide, and ethambutol. Both isoniazid and rifampin are taken for approximately 4 to 7 months, whereas pyrazinamide and ethambutol are administered for about 2 months. One of the major complications associated with anti-tuberculosis medications are drug-induced hepatotoxicity. Therefore, close and ongoing monitoring of liver function is required. This will be covered in further detail later in the presentation. When taking isoniazid, it is important to monitor for signs of isoniazid-induced liver injury, such as peripheral neuritis and elevation in hepatic enzymes. Adverse effects associated with rifampin include urine that is red or orange in color, nausea and vomiting, purpura, and hepatitis. Pyrazinamide may result in adverse effects of hepatotoxicity, hyperuricemia, stomach discomfort, joint pain, and rashes of the skin. Adverse effects associated with ethambutol are similar to those of isoniazid, such as peripheral neuritis, an elevation of hepatic enzymes, and hepatitis. Pharmacological treatment of latent phase tuberculosis is similar to that of the active stage. Generally, isoniazid and rifampin are taken once daily for approximately 3 to 4 months. It is important that latent phase tuberculosis is treated as to prevent its progression towards active disease.
Individuals with tuberculosis must be placed under airborne isolation precautions. This includes placing the patient in a negative pressure room, donning the right PPE, including a fitted N95 mask, performing proper hand hygiene, monitoring the patient for a fever, as this indicates the continuation of an infection, and ensuring proper disposal of soiled and/or used items. It is also important to identify individuals who have had close contact with the patient. In addition, the nurse must identify individual risk factors for the patient's reactivation of tuberculosis, such as alcoholism and cancer, so that the patient can alter their lifestyle to reduce the incidence of tuberculosis exacerbation.
Interprofessional collaboration is closely linked with the nursing management or interventions present on the concept map. Dietitians are responsible for determining the reason for the patient's diminished appetite. Immigrants often face difficulty adapting dietary accommodations and face a cultural shift. Undernutrition and tuberculosis are closely related, and the patient's weight loss should be monitored during treatment. Diet recommendations should include foods high in protein and carbohydrates and should also be in line with the patient's cultural diet. Respiratory therapists will encourage client to be in semi-Fowler's position, to deep breathe and cough, and to use an incentive spirometer to promote lung expansion. Client should be suctioned if unable to create clear secretions, and oxygen can be administered if client has shortness of breath. The respiratory therapist should also closely monitor ABGs, SpO2, and other respiratory complications. Social work will reassess the client's depressive symptoms and determine if client has appropriate coping skills with regards to his wife's passing. The social worker must determine how the client is adjusting to life in Canada as an immigrant and if he feels supported by his daughter in Canada. Determine if the patient will benefit from a psychiatric consult or if the client would consider medicinal or therapeutic interventions for depression. IPAC's assessment will result in the patient being placed on airborne precaution, as it is standard for patients with tuberculosis, with an isolation room and N95 masks in place. The patient must be monitored for his fever. Pharmacy will work collaboratively with the physician and nurse to determine if client is having any adverse reaction to pharmacological interventions, including nausea and vomiting, hepatotoxicity, and pruritus.
And with that, our comprehensive view at pulmonary tuberculosis is complete. We went over the assessment findings, symptoms, pathophysiology, nursing management, and interprofessional collaboration. Have you seen a patient with TB? Let us know in the comments down below.